Welcome to the Diabetes Alert virtual town hall born out of the DR Barometer program. Our speaker today is Dr. David Chaney. My name is Supriya Venigala, Project Officer with the IFA, and I will briefly review logistics. A reminder that this town hall is being recorded and streamed live on the IFA Facebook page. The town hall begins with opening remarks, which will be followed by a moderated question and answer session. Please use the chat function along the bottom of your screen to indicate that you have a question or a comment, and we will call upon you to pose your question. If you have resources to share, please post them in the chat as well. Video recording and resources will be compiled at the end of the town hall and posted on the IFA virtual town hall resource page, as well as the DR Barometer program resource library webpage. Following the town hall, you will receive an email with these resources and an invitation to the next town hall in the series. It is now my honor to introduce IFA's Secretary General, Dr. Jane Barrett.
And thank you very much, Supriya. Today we have the great pleasure to be in conversation with Dr. David Chaney, a person whose career has been in public service in diabetes education. He's a nurse by qualification, completed his PhD on structured diabetes education for adolescents between the ages of 13 and 19 years. Currently, David is the Assistant Director for Local Impact at Diabetes UK. He has 9 managers reporting to him on a weekly basis, I think, with responsibility for 8 teams across the United Kingdom. Previously, Dr. Chaney worked as the National Director for Diabetes UK, Northern Ireland, between July 2015 and April 2017. Prior to this appointment, he worked as the Senior Education Specialist at the International Diabetes Federation. And it's at that time that David and I were connected through, as Supriya said, the Diabetic Retinopathy Barometer program. And we certainly welcomed the International Diabetes Federation at that time, to be a partner in this important body of work. Within his role at IDF, he was responsible for the delivery of diabetes education projects around the world. So he not only has a passion, I really believe that that's his calling in his life. But what's most important also about David is he's just a delightful gentleman. He's a lover of dogs. He's a runner of all distances and marathons in particular. And he's completed several Spartan Super events. And that means that he's completed 8 miles, 29 obstacles, rising to an elevation of 1,125 feet. So it's a great joy, David, that you're with us today and that you kick off our Diabetes Alert series. So the floor is yours. Thank you.
Thanks, Jane, and good morning, afternoon, or evening to all, wherever you might be around the world. I'm absolutely delighted to be here, and thank you for inviting me to come and talk to you around diabetes. I'm very conscious it's a very varied audience that I'm speaking to, so you'll forgive me if some of the information I'm giving you may know already, and I'm hoping not to give too much of that. Obviously, there's a very limited amount of time and there's lots to talk about in diabetes. And as Jane will well know, if you're talking to me about diabetes, I could probably stay with you for the week and not even rest on talking about it, because I'm quite passionate around diabetes and the care that we give in respect of diabetes and what that means for people who live with diabetes. And just to clarify, when I say people living with diabetes, I think it's really important, that term, because diabetes just doesn't only impact the individual who has diabetes, but it impacts those around them. So that's why you'll hear me talk about people living with diabetes, because it reflects on those who have the condition, but also those around them who support them with that condition. Just a reminder that there's predominantly 2 types. Type 1, which is an autoimmune condition, no insulin produced by the individual. And type 2, which is a more complex condition, has genetic lifestyle factors, tends to be people who are obese or overweight, and 70 to 80% of the time, and has insulin resistance as well as part of that. But no matter what the type of diabetes that you have, we would advocate that there are 9 care processes that everybody should receive on an annual basis to help them to manage their condition. And they include things like blood glucose monitoring, their eye checks, feet checks, lots of different checks that they need to do, and there's 9 in total. Currently, the pandemic has put all of that under a new spotlight. And unfortunately, those care processes have become delivered in different ways or not delivered at all. And what I'd like to do is focus today, if I may, around the impact of COVID-19 pandemic on diabetes care and self-management and the challenges and the opportunities that it presents to us as we go forward. In current healthcare systems, we're struggling to cope with routine care as a result of the influx of COVID-19 patients, social distancing measures, redeployment of staff, amongst other things. And yet we have people who are living with diabetes who are nervous and anxiously at home, trying to contend with their condition at the same time as being exposed to this new threat that's around us within the world. That means for many people, they will not receive the annual checks. And so self-management of diabetes becomes even more important at this time. To do this, people need help. And therefore they need to have that knowledge to them. And I've shared, and there will be further resources shared from Supriya in terms of some of the things that we've done. In Diabetes UK, we normally would have advocated for 15, what we classified as healthcare essentials. We've had to restructure that and talk about what care to expect during a pandemic to support people with that knowledge. So people need to look at their feet and be able to look at them themselves and to decide whether or not they need to contact a healthcare professional, because the chances are they may not get a foot assessment during this year and may not have got one last year. Therefore, there are opportunities to go to online forums, also to what we classify as our learning zone, that people can access for free and go in and learn how to do a foot check and be able to look at their feet and examine what it is that they need to know and understand, and then when to make that decision. Because it's not always easy for people to know, and they feel quite anxious about making connections with healthcare professionals, and especially at this time where they're seeing them as being overburdened, and people are often reluctant to make the contact. What they don't really understand and realize is what might seem like a simple issue to them can often be a much more complex issue. And if they don't make contact now, there are devastating consequences further down the road, which they could have offset by simply making contact at this moment in time. So we would encourage people to go in and learn about that self-management, to look at their blood glucose levels, think about when was the last time they had a long-term blood glucose called a HbA1c taken, which looks at the blood glucose across 8 to 12 weeks and gives us a good indication of that person's control. We also need to think about what care they expect, and the health systems need to be communicating effectively with people to tell them that although they know they can provide routine care, what care can people expect at this moment in time? How is that being delivered differently? How are we working through so people can know what to expect and how to access that care? Access is really, really important, and that information needs to be given to people. There's now evidence to suggest that some people living with diabetes suffer poorer outcomes if they contract coronavirus. And these are not limited to, but include those over the age of 50, those who have poorer control, which generally means a HbA1c of above 75 millimoles or over 9%, and those who already have diabetes complications for which they're being treated. So it's really important now more than ever that people manage their diabetes effectively and have the tools to do that. For many, we need to recognize that this is a time of fear and isolation, and we need to be mindful of the increasing inequality gaps for some people and some audiences due to issues such as ethnicity and language barriers, access to technology, digital exclusion. And that can be for many different reasons. And we could have a whole town hall on digital exclusion alone, and also fear. We need to give people the opportunity to connect in different ways and to look at online as one means, yes, and looking at forums and discussion forums. But also it's not just about the learning about diabetes, but that social connection. And what we found is through working to our volunteers, when we put an online event on, it's done through a social environment that gets people to be able to talk to each other and just have that connection. And that gives a lot of benefit. And then at the end of those events, what we tend to do is bring in a healthcare professional or somebody with expertise to be able to help people to understand any questions or answer any questions they might have. But then we've also thought about how do we reach those other people and that don't necessarily do online? And how do we push out things like befriending services through telephone? Most people these days have a telephone. So connecting with people is really, really important at this moment in time. We also need to recognize that care has changed and that virtual clinics have become commonplace. So when I talk about the opportunities, there are lots of opportunities. We need to consider, though, those who are excluded, those for whom this work. And one of the things we've witnessed is we've witnessed people attending clinic who previously didn't attend clinic because it's online, because it's something that they can do. They don't have to take the time out of their day the way they previously did to take a whole day out to go to a clinic. It's a new opportunity for them to re-engage. So along with the poor comes the good. We also need to take the opportunity that this is a disruptor to the system. The pandemic is a disruptor, and that means we have a new way forward. We can look at new and innovative ways of going forward and not just simply return to the past, which didn't always meet the needs of people who live with diabetes. There's a clear opportunity to make care better going forward, to help people to understand what exactly they need and how they can have that, and to become more person-centered in the way in which we deliver care in the future. There are many areas that previously struggled with geography, and they were already running virtual clinics. And what's been really interesting is watching those areas fly and take off as other areas struggle to keep up, simply because they've become advanced in that area already. So we have already learning there that we can draw on from others and bring that in. Therefore, we have exemplar sites. We have people with best care models. Let's take those around the world, use them, and help us to bring forward what works really well for people living with diabetes. Some of the things we've also noticed and that we need to pay particular attention to as we go through the pandemic is that people are being prioritized for care because we've had to do a prioritization in order to ensure that those who most need care at this time receive it. But when people are being called forward, they're not always attending. Indeed, up to 75% of people in some areas are not attending for eye screening, even though they were the ones that were prioritized because of poorer control in the past. And so we need to reassure people and to understand why they're not attending. The most common reason given at this moment in time is fear of contracting coronavirus when they go into a healthcare setting. And we need to reassure people that at this moment, we are putting in the appropriate precautions right across the world in terms of our healthcare delivery models to ensure that they do not contract coronavirus. And it is really important that they attend for these appointments, especially given that they're the ones who have been prioritized. We're also seeing a reduction in the number of people that are being diagnosed with diabetes. And whether that's as a result of people not presenting for routine care to GPs, where often type 2 diabetes was picked up, or whether it's a result of some other means and mechanisms we need to fully understand. But we do need to drive forward the awareness of the public and the population that diabetes has not gone away. And that really is worrying to us, that people are sitting potentially with diabetes, which is not being picked up or presented very late in the day. And we've seen that, especially in younger groups, where they're presenting in a condition called diabetic ketoacidosis, which is a life-threatening condition, simply because they don't recognize the symptoms and the signs of diabetes and making contact with healthcare professionals at an early stage. And so we need to think about not only the system, but the people who are at risk of diabetes and how we support them at this moment in time, and knowing the symptoms and the signs and when to make contact in case they actually do have diabetes but not aware of the diagnosis. Final area that we need to be really thinking about is those at risk. Up until now, we had only recently developed new programs and new ways of prevention. So looking at diabetes prevention programs, those programs were based on the fact that many people went and had a blood test, and if the blood test came back and you didn't have diabetes, but you did have altered glucose control, then we would actually refer you into a program. But actually the blood tests aren't being done now. And so we need different mechanisms of accessing those programs. And one of the ways that we've managed to do is we have a Know Your Risk tool that allows people to go online. And we've agreed with the England NHS that people would complete that. And depending upon the score, they may be automatically able to refer themselves into the program. And the program has now moved to an online program to be able to help and support those individuals. So that's just different ways, but across the world, we need to look at ways of how we can actually manage these sorts of areas. So if I have three key messages that I'd like to get across within this town hall, I would say that diabetes is primarily a self-managed condition. And this is more important than ever when we're not getting that care from the healthcare professionals that was previously there. And people need the tools to support them. The disruptor of the pandemic offers an opportunity to reset and review, to grab the innovation with the old and create a new normal for diabetes care that is better than what we had before. That we need to pay particular attention to the less heard groups, those deprived and those from ethnic minorities, to ensure that any changes to care pathways reduce inequalities and don't increase them. I'm very happy to have a conversation and answer questions. Thank you.
Thanks very much, David. And I think, so we welcome questions and comments in the chat box. I've got a couple of questions to start off with. You know, in the last comment, you talked about less heard groups, and then you talked about the care pathway. And you and I have, talked long and hard about, the care pathway, for a person that's newly diagnosed with diabetes, and the importance of ophthalmologists being involved or podiatrists being involved. Could you just talk a little bit about this care pathway?
So diabetes, as I say, is a complex condition. And when I talk about less heard groups, I'm really deliberate in my language, if I'm being really honest. And the reason why is we often hear people refer to hard to reach communities. And when you speak to those communities, they say, we're not hard to reach. The system just doesn't know how to reach or engage with us. They're not hearing us. They're not hearing what we need. And therefore, it's more important that we talk about less heard rather than hard to reach. And we got that from the people who are struggling at this moment in time. In terms of a care pathway, diabetes doesn't only affect your glucose. You'll have heard me talking about feet. You'll have heard me talking about eyes. It affects kidneys. It affects multiple organs across the body. And therefore, it is not sufficient to have one individual necessarily dealing with diabetes, but you need a multidisciplinary team. That team becomes involved in care at different times. At diagnosis, it's a really difficult time for people with diabetes because there is so much information to take on. And what we've learned is that if you drip feed the information and give people the first snippets around diabetes and diabetes care, then drip feed the remaining pieces in and bring in those support services, those other healthcare professionals as you go through the journey, is a much better way than trying to do everything at once. These are often people who are trying to get used to medication, injections, blood glucose monitoring. What do we mean about a low blood sugar? What does that feel like? What's a high blood sugar feel like? So that's the basics of information without needing to go into then the complications and doing assessments right across.
I think it's really interesting that you said, what does it feel like? That there's a feeling related to, low blood sugar. I think that's a really important point there. I'm going to ask you'll have to help me with your name, and Iragua Moses from Uganda. So welcome, sir. It's good to have you with us again. So could you pose your question to Dr. Chaney? You're on mute. Great.
Hello, can you hear me?
Yes, perfectly.
Mine wasn't a question, it was just an experience about how we've tried to address the issue of handling diabetes in Uganda. one of the programs we have is through specially trained village health workers. These are people in the communities who are able to reach out to people in their homes, and we've been able to train them in screening and being able to reach out to people with diabetes. So through trained health workers who work with people in a district hospital, they're able to send medications and go out in the villages and they deliver this medication. Thank you.
Okay, thank you. David, you've got some experience in working in low and middle income countries. Can you just talk a little bit about that?
Yeah, absolutely. I think it's really innovative what those countries have done and how they manage the resource around diabetes. And I think often we look and we say, how can we transfer best practice from the higher income countries to the lower income countries? And I think there's actually a reciprocal process here, because what we're witnessing is innovation within those countries that have a limited amount of resource to be able to deal with diabetes. And we can equally transfer some of the learning there back up to the higher income countries. If you take, for example, and I've been to Africa and I've been over and I've seen some of that work and action around local community workers going in to deliver care in a local community and doing it in that way, and it works fabulous. They also tend to use a lot of mobile phones, which is a really unique way of connecting with people and bringing them in. But if you go to Brazil as well, I went to Brazil where they said we have a real challenge around diabetes. And what I found was in the state of Sao Paulo, for example, they had a dietitian or nutritionist that went into all schools with a child that had diabetes to set the meal plan for that child and to actually make sure that that child had the appropriate nutrition for their condition. And I looked back then at a lot of the countries that I've worked in that are higher income countries. We can't accomplish that. And we have major issues and major challenges with school, to the extent of even children at school requiring a parent to go in at lunchtime to administer an injection because there's nobody there to give that injection. And that has implications for the parent and their ability to work, all of the things that come with that as well. So I think there's a lot of innovation across all countries. And what we need to do is look at what are the innovations and how best can we use them to improve care right around the world.
David, you've done a lot of work in working with adolescents. And as we move into the UN Decade of Healthy Aging, I'm wondering whether there is a conversation about a life course approach to diabetes management. So could you comment on that?
Absolutely. I suppose it's a really interesting time to talk about a life course approach to diabetes, because if you'd have asked me about diabetes 10 years ago, and you would talk about type 2 diabetes, for example, we would have said type 2 diabetes is a condition which is a progressive condition. Yeah. And over time, you will move from one medication potentially to another medication to insulin eventually. And what we've witnessed over the last number of years is a complete revolution in terms of remission. Right. And the ability to be able to place people with type 2 diabetes into remission. And we're seeing programs emerge, and they're very low calorie diet programs over a period. So the direct study would be one where it's over a 16-week period with the support of healthcare professionals and dietitian support and diabetes nurse specialist support and clinicians that gets people onto this diet and change the behavior. And they tend to lose quite a lot of weight. And what we've witnessed is in the first year, they had up to as many as 50% of people with type 2 diabetes go into remission.
Right.
And that meant that those individuals no longer had the clinical determinants of diabetes, but we don't fully understand yet what does that mean, because we still need to follow them up to understand when we monitor the complications going forward, do they still exist even though blood glucose has returned to normal? How long does remission last for? Does it come back? And we've seen people as we follow them through go in and out of remission. So that in itself, as people get older and move on, is one of the things that we need to pay attention to. There's also the whole issue of aging in itself and people's response and what that looks like. And when you become very active or when you become less active and the impact of that on your diabetes. Also, people as they get older saying, I'm feeling tired, it must be because I'm getting older. When in fact, it's nothing to do with them getting older. It's because their diabetes is out of kilter. It's not working well, and their blood glucose level is high, and that will impact by making them more tired as well. So I think there's numerous ways to look right across the lifespan at diabetes, right down from birth right up to terminal care or palliative care, because there's lots of different stages in life, and diabetes will impact on them all. And we need to look at the pathway and the journey that supports people best across those stages.
You know, your body of information is just incredible. Do you know, I hadn't really thought about, people who say, I'm really tired, and the link back to diabetes. So, you're a fountain of knowledge. I just want to now go and talk about COVID for just a minute. There's lots of conversations about, well, I don't want the vaccine because. So in terms of your field, what's Diabetes UK and the local impact? What are you saying to people with diabetes?
We encourage everybody who's offered the vaccine to take it, who has diabetes. We're very much behind the vaccine, and we support the vaccine rollout in any way we can. And we're trying to reassure people. So what we've been doing, and I would say keep an eye on our website in terms of events and our social media, because we're hearing the voices of people living with diabetes who are coming forward with the anxiety of, do I get this vaccine? Do I not get this vaccine? Which vaccine? Do I take the BioNTech vaccine? Do I take the Oxford vaccine? And that's coming out as well. And what we're saying is, if you're offered a vaccine, you take the vaccine. A vaccine in your arm is better than no vaccine at all. So it doesn't matter which one. They're all being shown to be, the efficacy is really good for these vaccines. What we're also seeing is the impact of COVID on people living with diabetes. And I've referred to that a bit earlier on. It is really important that people get vaccinated when they're offered this. Although we do understand that people do have a nervousness. And what we do is we run events and we bring forward those. I'm not a vaccine specialist, but we bring them into those events to explain. Often people feel it's the timing. They feel it's been rushed. Hang on, how come it took so many years to have that big vaccine, but we can have this one in so many months? The reality is the methodology behind the development of vaccine has already been in existence. And when you put the world's best scientists behind this, which is not always behind every vaccine, and you throw the amount of money at it that's been thrown at it because this is a world issue, you're going to get movement quicker, but it's based on previous existing known knowledge that we're able to put in and drive this forward on a much quicker way and be able to deliver out the outcomes in respect of it. So we would encourage everybody, where possible, to access and get a vaccine.
And we'll really welcome any links to your websites. Supriya's putting a lot of information in there now. So, we will have a package of information that goes out to our tens of thousands of people. So, please watch out for that. I want to go back now and just talk briefly about something you said about ketoacidosis. And, you're seeing in this time of lockdown where people should be seeing a clinician and are not, but don't know what they're experiencing. Could you just unpack that a little bit for us?
Yeah, absolutely. So the ketoacidosis refers to type 1 diabetes. It occurs normally, it can occur when people have diabetes if they end up not taking their insulin, or if they actually haven't got sufficient insulin within their body. And what happens is the body starts to break down the fat tissues within the body, and that produces ketones, which are an acid to the body, and therefore the blood level starts to turn towards acid, and it makes them become very unwell and very ill, and it can be life-threatening. And there's lots of different symptoms around that. So people might become thirsty, they become tired again, they may lose weight as a sign of all of this as well. They may become grumpier than usual, and they actually may be running to the toilet quite frequently. So the 4 ones that we talk about are the tiredness, the thirst, they're 2 key ones. The loss of weight is a 3rd one as well. And there's lots of then the change in personality. All of that happens at this time. People's tiredness. So tiredness is the other one. So what we say to people when they're undiagnosed with diabetes is if you're experiencing these symptoms, you really need to contact a clinician. You don't wait. Unlike type 2 diabetes, which is quite an insidious onset quite often, the symptoms aren't quite as overt. They're not quite there in the same way. With type 1, it's much more overt. That occurs generally over a period of a week or a couple of weeks. And people think, oh, you know, I'm just tired again, or I'm just thirsty, or I haven't, the reason you're going to the toilet is because you're drinking a lot. We come up with the best of excuses not to go and contact a clinician. And what we need to do is actually recognize this could be a symptom of diabetes. And when you go and make that call, a simple urine test or a simple blood test, finger prick test, will tell us, is it diabetes? And if it is, then the appropriate treatment will stop people going into that state of diabetic ketoacidosis. And it's really important that they get insulin in and they also get fluids in, because often they're dehydrated at that time as well. You would say, well, dehydrated, but they're drinking a lot. Yes, but as much as they're drinking, they're actually peeing a lot. They're going to the toilet quite a lot as well. So therefore, they're losing the fluid. And because the sugar that you ingest isn't getting into the muscle tissues, that's why you're losing weight. And because it's going through your kidneys, it's drawing more and more water in. And that's what's causing you to go to the toilet quite a lot as well. So you end up becoming quite dehydrated. So it's really important that people understand and know these symptoms, these signs and symptoms, and act on them.
I want to now flip into austerity measures. One of the areas that we're very concerned about in COVID is, you know, the stimulant packages that have had to be put into, you know, most countries of the world, and whether that will impact, you know, the ability of governments to invest in such important programs such as, you know, promotion and prevention. You know, do you get a sense, because you work very closely with government, do you get a sense of, you know, whether there'll be a pullback on these or it should be more investment? Do you get a sense of that?
I think it hasn't fully come out yet, is what I would say. There's certainly been a connection in terms of there's a reorganization yet again of the England Health Service. We can see that happening at this moment in time. What that means, we're not quite sure. In Northern Ireland, I'm recognizing the fact that there is that sense of we need to save some money. And that's coming out. So I think it's very much dependent upon the country, but we don't fully understand to what extent. And what we're saying is where we have existing services at this moment in time, and just remember those services might need to evolve or take on board the innovation that I was talking about and be delivered in different ways. We're arguing that those services need to stay. They don't go. You can't suddenly pull a service out that's been in existence for a long time, especially when there's a clear need for that service. So you really need to look at that. I think there is an onus, and there's always an onus on healthcare professionals and us as a group of people who support the system to look at, can something be delivered differently? And is there a cost-saving measure in that if we need to do a cost-saving measure? Not necessarily to give it back, but actually to invest further. So it's not about saving money to give back, but saving money to be able to deliver more and better for people who live or who are at risk of diabetes.
Do you know, many of the people that you deal with on a daily basis are frontline workers. And if they're not frontline workers, they're second line workers. So what are some of the pressure points that your colleagues are feeling at the moment, you know, working in the field?
They're tired, they're exhausted, if I'm being really honest with you. That's what's coming through. And it's relentless is the word that keeps coming through. It's never ending. Every day they go in, they're working long hours. They're trying to deal with COVID, but at the same time, and the social distancing measures they have to take into consideration means that they're not seeing the amount of people that they would have seen previously. In dealing with that, they're also trying to deal with their own and internalize their own risk within this environment. And not only their own risk, but the risk that they're taking back home to their loved ones. As well as that, they're trying to give what they can to people and invest in the best way they can to give the best care possible. And so when you put all of that together, the stress and the strain of that on a day in, day out basis makes it really challenging. And what we've actually as an organization done as part of this is we've looked at the emotional and psychological support that not only people living with diabetes need, but the healthcare professionals need as part of their job in delivering. And we're seeing that come out more and more. We need to pay attention to that to be able to give them support. The other thing that we've seen is we've developed coaching skills. So we've developed a number of coaches within our organization. And as an offer, we're going back out to healthcare professionals and we're saying, you know, here's a coaching offer for you. If you're feeling the strain and distress at this moment in time, we're happy to provide a coach to be able to support you at this moment in time. Sometimes it's helpful just to talk things through with a view to looking at how things might go forward for you better in the future and exploring how I might be a better me, or how if there's a particular challenge I'm dealing with at this moment in time, how I might overcome that. So what, as an organization, what Diabetes UK is trying to do is it's recognizing that it needs to support people living with diabetes and at risk of diabetes, but we also need to support the system and professional colleagues who are delivering and going above and beyond at this moment in time in a really challenging environment.
You know, you've just described a model of best practice, David. I mean, you know, I hope this is being written up because it really, you know, what you're saying really personifies, you know, what I know of you, you know, caring about other people, and then you care about yourself. So it really is developing community support systems. So I thank you. Andra Stenku. Andra, your question?
Thank you, Jane, and thank you for the wonderful presentation. I'm wondering, with COVID, as lockdowns have impacted our lifestyles, our eating habits, our drinking habits, is there a greater risk, or what is the impact on the risk for developing diabetes? Is there a greater urgency for screening, or at minimum knowing those feelings, what to look for, what are the symptoms? And perhaps if that link does exist, can that be a tool for advocating for better investment in programs and services?
It's a really good question, Andra. Areda. It's really interesting because I think we're at very early days at this moment in time. We don't fully understand or comprehend. You'll hear reports of the COVID stone, and that's referring to the extra stone in weight that people are putting on as a result of the lockdown and the impact on their lifestyle. I've heard of people coming out of COVID in one of three ways. Basically, some are coming out fitter. These weren't the words that were used, as you can imagine. Some are coming out having taken on extra alcohol and gone in that direction, and some are coming out much more overweight. And I think there's individuals, it's really challenging, especially when you're in lockdown and you've all of the pressure of isolation and all. You can see how people turn to alcohol and comfort eating. What the direct impact of that on development of type 2 diabetes, because that's where it would focus. It wouldn't be on development of type 1. Type 1's an autoimmune condition. On development of type 2, we don't yet know. What we are seeing, interestingly, is that type 2 diabetes is increasing in the people who are being treated for COVID. And we're seeing that as a result of the drugs used. So dexamethasone, which is a very powerful steroid, we end up with steroid-induced diabetes in some people. And whether or not they then revolve back to not having diabetes after they come off that medication, we don't know yet. Some do, some don't. And so therefore we may see an increase. What we need to understand is whether the increase is due to the lifestyle measures you're talking about, or whether the increase is due to the treatment, or whether the increase is due to something else. And when we fully more comprehend that, I think we may well be in a place to argue that there needs to be more investment. I think we're already talking to governments, certainly within the UK, around weight management and supporting that, because we recognized before ever we went into the pandemic, that was one of the issues we struggled with, and there's one of the leading causes of type 2 diabetes, and therefore we need to get on top of that.
Great question, Andra, thank you. I want to turn to technology. You know, technology is everywhere. You know, to what degree is technology improving the capacity of people to self-manage? And if so, does it actually form a barrier for certain population groups?
Again, another really good question. Technology is wonderful, but technology can also be a barrier. It can be both of those things. So if you speak to, and I was in a conversation the other day with someone who had type 1 diabetes who hated going to diabetes clinic. Every time they went, they felt they were taking the time out to go and they didn't feel they were getting the benefit. And they've moved to a virtual consultation, which they had earlier in the week with their consultant, using their Libra, which measures their blood glucose and is able to download their phone and sent off to their consultant who reviews it and looks at it with them and has the conversation based around that information to say, okay, let's have a conversation about what's going to work for you better going forward in the future. And it was a 15-minute consultation, whereas previously they would have taken them hours out of their day to go along, then go in, go through different processes. And they firmly believe they got more out of that 15-minute consultation than any of the other previous consultations that they had attended. And they felt heard as much as anything else, because it was no longer a rush to get through, but actually the opportunity to speak. Conversely, when you speak to some of the older population, and I don't think we can actually generalize, because it's not just older populations, and it's a tendency to do that. Many of the old people, I look at my father's 83, he's a wow on technology in terms of being able to do his emails and everything else. You can't just do it in that way. At the end of the day, there are populations, whether it's because of deprivation, whether it's because of access to broadband as a simple thing, or access to the technology to be able, there's two types of technology. There's the type wearables for people living with diabetes that helps them to manage their condition, and there's the type to help us to engage with the system to get that consultation. And some communities find both very difficult. Some find the technology to engage with the system difficult, but actually get great benefit out of the technology, the wearable technology. But then there is also the issue of who gets the technology, the access, the inequality around that. We know, for example, that within the UK, those from an ethnic minority group are far less likely to have access to insulin pumps, far less likely to access to the Libra device, the flash glucose monitoring, or the CGM, continuous glucose monitoring devices. Yet at the same time, they would benefit greatly from them. So we really need to look at that. I think there's a whole complexity within that area that we could speak about here for, I'd say, 2 days and still not come up with the answers, but we do need to look at it.
Look, thank you. Supriya, you've got a question?
Yes, hi. Great talk, Dr. Chaney. I wanted to ask, what are some of the opportunities for healthcare professionals that have been identified during this time?
I think, again, it's a good question in terms of, so there's lots of different opportunities for them to look at how they're delivering care at this moment in time and what works better for them going forward, as much as what works well for the people who are receiving care. Many healthcare professionals are finding that because they're engaging and being able to engage through technology, they can see more patients within an hour than they previously could, which frees up time for them to be able to do the other work and concentrate on those people that do require that face-to-face element and bring them in and have that extra time to be able to do their job. That brings greater job satisfaction for the individual involved. But that's, I would suggest, we're not there yet, because they're doing it within a world of the pandemic at this moment in time. So it's not like they're doing it out of choice. They're doing it because we've been made do it. It's interesting when you look at it that we've all been pushed down this whole avenue of IT, and we've pushed in that direction. We didn't choose to go in that direction. Coming out of it, will there be a rush back to face-to-face? And there potentially will be for some people. But then a little bit further down the road, will the pendulum swing back slightly to a mix? And I imagine that's where we'll sit better, is with that mix. The other thing for healthcare professionals is in the learning of the services that they provide and how they offer them. Not just diabetes, but where you have people with multiple comorbidities, and there are so many of them. How do we join up a system that allows us to bring those individuals and the multidisciplinary team together so that people aren't going from door to door, but actually have a group that are able to review and talk to them about something that's meaningful and allows them to understand their condition better and how to move forward with it. And finally, it's around healthcare professional training and resilience. How do we manage that better? What do we take from the current situation that enables healthcare professionals to think about themselves and how they manage through times such as this? A pandemic, we're told, is once in 100 years. We don't know the reality of that at this moment in time. I don't think we were truly set up for this one. And there's lots of lessons we can learn from that across the health system. And how best do we do that?
Thank you. And no, we weren't set up for this one. No, you're quite right. So Rose Gahir, would you like to come forward and ask David your question?
Yes, please. I was asking what have we learned from COVID-19 to strengthen healthcare for older people, for older persons?
Thank you, Rose.
I think the key message around this is that we need to be prepared for those type of disruptors that we haven't been prepared for. And we need to have mechanisms in place to say, what are we going to do to support individuals as we go forward? It's really interesting that we've concentrated an awful lot on the acute side of care, and we've needed to do that. But actually, that has been to some expense at the chronic side and those with chronic conditions who are trying to manage and continue on. And so there's something about understanding how do we make the system flexible to be able to deal with crises like these within the acute setting, but also build up that resilience and support that's needed within the community and utilizing the community assets that we have available to bring them into play when we need to support people who are not acutely ill, but are chronically ill and feeling isolated and vulnerable at this moment in time. I think there's a lot that we could potentially do, but we need to think it through, because we can't just simply imply an extra number of ex-healthcare professionals on the basis of we might get a pandemic tomorrow. We need to think about what is a sustainable way forward that allows us to respond, react in an agile way so as that no group gets forgotten.
What a great question. So thank you, Rose. Cynthia Stewart. You with us, Cynthia? Welcome.
Yes, I finally found the unmute button. Thank you for this wonderful presentation. Having worked in vision rehabilitation for so many years, I just wonder how exacerbated the pandemic has made it for people who are losing their vision due to diabetes and their lack of access during the pandemic, both to being able to manage the tech aspect of getting online, if at all, or even for compliance with taking medication, et cetera, in light of the vision loss.
It's a really good question, Cynthia. And unfortunately, I have to be honest and say, I don't think we've had the supports there for those individuals that they have required. And many of them have been felt isolated and left without as a result and struggling to cope and contend with the care that they need and how they access the likes of online technology and the supports that they need to do that. In addition to that, I would say that where we're trying to prevent sight loss and bring people in, you heard me mention earlier around the prioritization of bringing people in for retinal screening to lock or treatments around their eyes. What we're finding is because they're so frightened, because they feel so vulnerable, they're failing to access care. So even though they're being called in, they're choosing not to attend. The challenge in a pandemic situation, and I've only heard this in the last couple of days, is that when someone chooses not to attend or doesn't arrive, they'll then be rescheduled, and they'll reschedule obviously further down the list. But if they do that on a couple of occasions, they're being discharged back to primary care. And that also is something that we really need to be careful about, because it's about understanding the needs of the individual and how we reassure and communicate with them to get them to the appointment. For some, it's not the hospital environment, it's how they get there. So if I have to use public transport, how vulnerable do I feel on public transport in a pandemic? And therefore, how do we help people to navigate those journeys to get to where they need to get to have the care that they need, as much as being within the environmental provision of care? I'm also aware that there is a limited amount of tech support out there, I would suggest, around vision loss and diabetes. And I think there's something definitely for technology companies to look at. I remember the talking meteor when someone did their blood glucose level and it spoke to them and told them. And I think we need an array of those, to be honest with you. I don't think 1 meter is sufficient. I think people have different skills and needs, and we need to look at how we develop that technology. The easiest one for me with people given insulin, for example, is when they use a pen, and the clicking noise of the pen is what they use to talk about how they actually, what the dose is that they're giving. Which sounds great and brilliant, but I think we could become much more advanced very quickly if we put our minds to it, to be able to put in the supports that are required for these individuals to have the independence that they deserve to have in the management of their condition. And they shouldn't be placed in a position to have to give up that independence simply because the equipment isn't there to support them.
Right. Thank you.
And of course, David, you know, there are some things that we just don't know yet. So many people with diabetes may have had COVID and are long haulers that are, and we just don't know the impact that that's going to have on their condition, do we?
No, you're right. We don't have all the evidence. We're only gathering the evidence. And some of that evidence that's coming out, James, around long COVID, and people will have heard about long COVID, which is the condition that you have COVID, but then the symptoms go on for a much longer period of time in certain populations, and they end up with other conditions as a result of that. We don't know, but we're witnessing it happening. And so in the provision of care going back to diabetes, after the pandemic, when we get over the hurdle and we get the vaccines out and everyone's vaccinated, we also need to think about, is there particular clinics that need to be developed with that in mind that relates to people who have diabetes who are suffering from long COVID, or other conditions in that way as well.
So 2 more questions and then we've got Maria Peluso. Maria, would you like to ask David your question?
Good morning, and thank you very much. This has been very, very interesting. I'm just wondering, since diabetes 2 has generally been on the rise the world over, there are some countries, I focus on, say, Southern Mediterranean, and even some communities, such as Indigenous or Aboriginal people. I'm wondering what governments and what communities are doing specifically in those populations that have a higher incident and have been known for quite some time now, that have a higher incidence of diabetes 2.
Okay. Thanks, Maria.
Maria, I'm going to be honest with you, it's not my area of expertise, but what I will say to you on it is when I look at my trips to India, where I went over to India, where there is also a much higher instance of diabetes, what we found was that when you look at the culture and you look at how people perceive things, in India, quite often, when a child is that bit more plump, it's seen as being much healthier than a child who's not. And therefore, people are doing that, and diet has a big impact, and exercise around that development of type 2 diabetes. Sometimes what we need to look at is it's about the re-education of people and trying to get people to move in different directions to understand the consequences of some of what we perceive to be our normal behaviors on a daily basis that we really pay particular attention to and we think are really valuable. They actually are causing us some challenge and some harm in some respects, and we need to look at how we actually help people to have that cultural shift. You've heard me mention about diabetes prevention programs. From a government perspective, there's a need to look at those programs across all populations. One of the things that the UK has struggled with is it came up with a diabetes prevention program, which is a generic program. So therefore, when you get somebody who comes from a different ethnic background and they engage with that program, it's not as meaningful and you lose them. And they found that they're losing people from people from different populations simply because it's not relevant. So whatever program we decide to give or put out there, it has to be based on evidence, and it has to be done in a co-production model with the communities in a way that's going to meet their needs and keep them engaged. Otherwise, we've no hope of succeeding.
I just have another question, if I may. I'm sorry. I hope there aren't too many others. Much has been made with diabetes too about the importance of exercise. And I'm wondering what the role of sports and exercise programs at the community level may be, in fact, an investment in that, may be, in fact, very useful for controlling and possibly eliminating diabetes too, in treatment and in investment in sort of dealing with patients with diabetes too.
Your exercise is really important. But if you look at the direct study, and if you look at, that's the study around remission and type 2 diabetes, what they would argue and what they came out with clearly was that it was the diet and the loss of weight that was the most important element. The exercise came after that in terms of the maintenance of the weight loss. So the diet was what created the weight loss and the reduction in calories. That created the weight loss to begin with. But the sustaining of that weight loss was achieved through people increasing their exercise and changing their behavior and their habits. So I agree with you, exercise is really important. I would see it more in the sustaining of the weight loss. And I think there is an argument to be made about how we move people from where they're currently sitting with tech. And this is what we see all the time. I've 2 children in their teenage years. I witnessed them on games that are played. We used to play them with our feet. They're playing them with their thumbs. And at the end of the day, it's how we get that movement, that behavior out into a much more community exercise fashion and getting that community building together for exercise model that governments might be able to support. But I would argue that diet first and exercise then to sustain the weight loss is really important and to help people feel healthy.
Thanks, David. As we come to the hour, I'm just going to give you a couple of moments, David, to put your thoughts together to give us our takeaway messages again. In closing, I want to thank Dr. Supriya Venagala. Supriya is the project lead for the DR Barometer program of work and has just done an outstanding job in this town hall, but all of the other work around the DR Barometer. So please go to the website, drbarometer.com. Is that right, Supriya? DR Barometer. Okay. And join the community. You know, the IFA is in the business of helping to create an environment that enables an older person to do what they have reason to value. And one of the reasons that we're really interested in diabetes and working with IAPB and diabetes organisations, you know, is to ensure that the vision health of older people with diabetes is managed, and they have the most safe and effective treatments as well as access to screening. So please join us in this barometer community. So David, the last word is from you, but before I hand it over to you, thank you. Thank you for being our leader, you know, in this series, Diabetes Alert. And thank you for your frank discussion and the knowledge that you shared with us today. It's been inspirational to me. We should have you back again. So I'll leave it to you to take us out with your key messages.
Thank you. It's been a pleasure, and I'm delighted to be asked. So thank you very much. The key messages, I think, it's just to go back to them are, diabetes is not going anywhere. We can see that. And the most important thing, especially that has come out through the pandemic, is self-management and supporting people to be able to self-manage. Therefore, we need to look at ways that we can increase the effectiveness of how we can help people to self-manage their condition going forward. We have an opportunity at the moment. We see a big disruptor to the systems right around the world. So rather than just going back to what we had before, there is an opportunity to reset and revisit what we want it to be and try to put in what we believe is the best for people living with diabetes. And that should be done in co-production with people living with diabetes. And then finally, just to remember that anything we do won't work for all. So therefore, we need to make sure that we address in anything we do the inequalities that come up within the system constantly, and that we need to be able to do that in a way that allows people to feel that they're more heard and more engaged with the system and get better care.
Thanks very much, David. Thanks to Supriya and also to Berenice. And watch out for our next town hall in the Diabetes Alert series, which will be in a month's time. So thanks, David. Stay safe and stay well. And we'll see you all tomorrow for the IFA Town Hall with Dr. Olive Bryanton. So thanks, David.
Thank you. Bye-bye.